Good evening, sir.
Picture ready?
Good evening, sir.
Good evening. Are you ready?
Yes, sir.
Others are not ready.
Yes, sir. I'll call them, sir. Just a minute.
Picture, did you get these indices? Riksha, did you get these indices? Unmute yourself. You are muted.
Sorry, sir. Yes, sir. I got the indices, sir.
Okay. For multiple days or only one reading?
Yes, sir.
Indices?
Yes, sir.
No, for how many days you have got it? I think we have done multiple times.
previous reports, matlab, 2019 reports were pending. They were, matlab, I have to call them and ask them for the photos, sir. So got it.
And current also indices you got it. Okay.
I got all the indices, sir.
Okay. Others are not free, your colleagues.
Yes, sir. Thank you, joining, sir.
Monica, you can rename yourself. You can display your name. I hope you know how to do it. Anyway, Preksha, I think let us start it.
Okay, sir.
Good evening, friends. Welcome to this our Tuesday PG Clinic. I hope that some of you may be in the mood of holiday, but I think to continue the work is a good habit or idea. Dr. Preksha Dave,
Yes, sir.
GCS Medical College, is the presenter for today's case. And I request all the postgraduates, Dr. Mita, you can request them to join and participate in the discussion actively. Dr. Deepa Trivedi, hematologist, will join us after some time. Those who are on the attendees link, they can also put their comments and questions. And those even who wants to even the join on the screen, even they can request the DIP person, and they will get the panelist link and they can join for the active discussion and participation. Dr. Preksha, you can share your PPT and start the history part.
Good evening, friends. I am presenting a case of 4.5-year-old four and a half month year old male child, informant being mother, born from non-consanguineous marriage, residing at Amraivadi, Ahmedabad, Hindu by religion, was admitted on 1st September with chief complaints of cough since 20 days, cold since 3 days, fever since 2 days, and difficulty in breathing since 2 days. Cough which was initially dry, intermittent, then developed wet cough, paroxysmal, more during early morning, not associated with post-acid vomiting, not disturbing sleep, and from last 2 days, the cough is associated with breathlessness. Fever, which was non-documented, low to moderate grade, not associated with chills and rigors, relieved by medication, interfebrile period, child was playful, and difficulty in breathing in form of increased work of breathing and fast breathing. Negative history, there was no history of burning micturition and no history of contact with animals or any allergen.
Okay, Preksha, can you just stop sharing?
Yes, sir.
Here what she described, that 4.5 years old male child and cough of 20 days. I think first let us take the only symptom of the cough. And because it is significant complaint of 20 days duration. So any patient of cough, suppose comes to your OPD, what information you will gather? I think that is very important. Recently, even in one of the conferences last Sunday when I was there, and that for practitioners, even this was the issue, that any patient of the cough, then how this information should be gathered, so that at least you can have the idea that what is the likely problem or how we should go further. Vita, can you take it? Suppose any patient of cough comes to you, what information you will ask for and what is its importance? Tell you.
Sir, ask for productive cough or non-productive cough, or whether it is intermittent or paroxysmal or non-paroxysmal, and then ask for it is more
You give the importance of all these points. That for what you are asking. Suppose if it is there, what does it indicate? If it is not there, what does it rule out? No, we have to just not the points mechanically, but having this meaning importance. What should be the very first point? I will say. Wait, yes, Riksha.
The dry cough or wet cough.
Before that, for any symptom, suppose fever or cough, what usually we ask? What is the duration?
Yes, sir.
The duration is very important. Really it is significant or not. And even the onset, that how it started. And then you can go further. What is the importance of some duration, Bita? I said duration, but then you should ask the question, what is the importance of duration?
sir, if it is a short duration, likely of viral infection.
Okay, right.
Or it started with fever or not?
No, first discuss only the duration. Suppose short duration, most probably viral. But some other cough, suppose of long duration, 2 weeks, 3 weeks, 4 weeks.
Chronic.
Then what is its importance? What does it may suggest? Or which conditions may present with a cough of longer duration?
Sir, TB or bronchiectasis.
Tuberculosis, not TB. Always when we are speaking, we'll have to speak right. So tuberculosis. What else? Bronchiectasis. Okay. Then
pneumonia, sir.
pneumonia can be, why it should be of long duration? Right? Unless it is really some problematic pneumonia. And cough is not the prominent complaint in a case of pneumonia. So I think these are the things which you should come out with this. Suppose 1-year-old child, cough is of more than 1 month. And fever is mild. Fever is not important. Mild symptom. But main the cough of 1 month duration, more than 1 month. What you will keep in mind? And what next question you will ask so that it becomes clear. I think keep in mind the common conditions. Common conditions should be kept in mind. 1-year-old child, cough of 4 weeks, 6 weeks. Yes, Arjun? Janmejay. 6 months, 1-year-old child, cough of, and disturbing cough, significant complaint. It is vaccine preventable. Why do you forget it? Ita. But you see, so why it requires so much time to think? It's very common. Any patient of long cough, then definitely, and then you can ask the details of the cough, that what type of the cough, that would make the point clear, description of the cough, right? So even any chronic condition, tuberculosis, bronchiectasis, absolutely right, whooping cough, right? And suppose if it is a recurrent cough, then what can be the reason? Cough is recurrent. Cough was there for a few days, suppose 5-7 days. In between, then the child is all right again after 2-3 months or 1 month, even the cough, even it subsides. What can be the reason? What do you call it? I am asking from the duration point of view. One is the short duration viral. Long duration may be the some chronic infections like tuberculosis, bronchiectasis, pertussis, and so on. Sometimes viral infection also, they may present the prolonged cough. In a case of even respiratory syncytial virus, adenovirus, recently we had the season of adenovirus. Not many patients cough for a very long time. But here I am describing different type of cough, that the cough for a few days, then the child recovers totally, and then again the child develops this cough. This type of the recurrent cough is going on, sometimes maybe even breathlessness, and recovers. Cough is paroxysmal, nocturnal. What is the reason for this? Why it requires? I am not asking uncommon condition. Very common. Divya? The fever may not be the important. Mainly the cough, and cough is the paroxysmal, nocturnal or early morning cough, and it is in the form of the recurrent cough. Why it requires so much, I will say, time to think. Several times we have discussed that this type of cough is common with this bronchial asthma. Bronchial asthma, not necessarily every patient will present with the breathlessness. Cough also may be the presentation of this bronchial asthma. That we should keep in mind. Right. So onset, even I asked the onset. If you can you give an example that onset of cough is very important for diagnosis? Sudden onset.
Foreign body, sir.
Foreign body. Sudden onset. Otherwise, child is healthy and hearty. There is no problem playing, right? And suddenly the child, there was the choking and the cough. That is a very classical story of foreign body in the children of 6 months to 2 to 3 years. Age is also very important. What is actually my point? That please, for each symptom, read in the details and then ask the question and gather the information. That will give you the idea that what is the likely reason, how you should proceed further. I think in this recently published book, Signs and Symptoms, please, all these common symptoms are included. I think one should go through it. Most of the times common conditions will get, of course, uncommon conditions are not included. But the foreign body, viral cough. Now, suppose this type of cough is there, always try to go in the details of the analysis. As already Mita was telling, That cough starts with the fever and the very bad cough, and then gradually it disappears. That is a very common story in a case of viral. But as I was talking already, that recurrent cough or cyclical pattern of the cough, paroxysmal pattern of the cough, is a characteristic of hyperreactive or bronchial asthma. Similarly, suppose the cough is continuously and more than 2 to 3 weeks, it is a persistent cough. What does it indicate? Which infection? Which chronic infection? Hetvi.
Tuberculosis, sir.
Tuberculosis, but why it requires so much time to think? I talked to you that in one of the studies in Africa, they found that the different type of cough that usually cough starts very bad and declining, sometimes maybe the prolonged cough also in viral. As already I was talking in adenovirus, it takes more time. Even respiratory syncytial, sometimes the weeks together. But most of the times it gradually decreases. While recurrent cough is allergic or hyperreactive or bronchial asthma type. The cough will be there for a few days, patient recovers, again after some time comes back with the complaint of cough, and that type of the multiple episodes. While cough is constantly since suppose few weeks or months, and it is not decreasing, even on the contrary, sometimes increasing. That is what we say, what is the characteristic, what is the adjective of that cough? Or somebody may ask in the exam in this way, even in the DM pulmonology, they are asking that qualify the cough for the tuberculosis. Divya, are you able to recollect? Very specific adjective is given. That is a non-remittent cough. That means constant, persistent. It's a non-remittent. Non-remittent cough of more than 2 weeks is one of the points for consideration of the tuberculosis. What was my point? That always go in the details, and that will give you lot many ideas. So the cough has a onset, then duration, the type of the cough, even you can go. Tanvijay, can you give some example types of cough and some likely etiology? That these are the cough is common with this condition. Can you give some examples?
So, yeah, in coughing bouts, coughing bouts with condition associated with pertussis.
Okay, very good. You can simply say it's a paroxysmal. It's an episodic, right? That is the classical example of pertussis or even the bronchial asthma. That can also come in this way, right? Good example. Can you take some other examples like this?
Sir, barking cough is seen.
Very good, very good. Preksha, barking cough is the characteristic of
Laryngomalacia.
laryngitis.
Laryngitis.
Any condition where larynx is involved.
Yes.
Most commonly laryngitis, but of course laryngomalacia. Laryngomalacia cough is not the prominent complaint.
Yes.
But any singer's reason, exhausted suppose some singer and the cough develops, that is a very classically barking cough. Or laryngitis in a viral infection, many of us sometimes develop, right? So that is the barking cough. Very good. Like that. Can you give some example? You can remember some examples so that it becomes easy for us. Try to find out. Yeah. Yes.
Cough is seen in
Yes. Scatico, right?
chlamydial infection.
Scateco cough is characteristic of Divya?
Chlamydial infection.
Chlamydial infection. Very good. It's a chlamydial infection. So, you know what is my point? That if you have suppose signified or if you're located one particular point, you can diagnose the condition without even going much. Sometimes investigations may not help you, but this characteristic will help you. So in the cough, go for the duration, onset, type, right? Then even the progression, whether it is increases or decreases, which already we discussed. If someone decreasing, what commonly the viral, continuously increasing maybe chronic infection like tuberculosis or some other reason, some pressing over it, maybe the lymphoma, maybe the vascular ring, any condition. Even associated symptoms, right? With the fever, probably infection. Mild fever, maybe some chronic infection. Weight loss probably signifies for tuberculosis or even the malignancy. Right. So associated symptom. Suppose child is breathlessness and edema, maybe the cardiac cause. So try to find out these associated symptoms or associated signs. That will give you the idea. Then even sometimes the drugs. Which drug can aggravate the cough?
AC inhibitors.
Very good, very good. AC inhibitors. In adults, we are not using much, but in the adults, commonly they are using for the hypertension. And many times the patient will come back. Yes, sir, I'm better from the hypertension point of view, but the cough is quite disturbing. And that is simply due to drug. So that is very important. Suppose it is a cough during the lying down position. What conditions where the cough is precipitated or aggravated in the lying down position?
Postnasal drip.
Very good. Postnasal drip. And that can be a case of chronic sinusitis. Right. Postnasal drip. Any other condition, Hetvi? Where in the lying down position? Somebody said,
Mitral regurgitation.
okay. By the mitral regurgitation, the lying down position, it will be increased. You know, lying down position, that means due to the position, there is some problem. Here we know that lying down position, what happens, that the sinuses, what is the collection that trickles over the pharynx and then it causes the cough. Similarly, GRD, so the reflux disease, you know, lying down position, the reflux is there and the cough may be there. So these are the things I think how you should go for any symptom. Please, I think you should be prepared. Common symptoms are not many. And just if you can go through, I have tried to give the ready retinol. Hardly takes, I will say, few minutes, but will lead us to lot many informations. Another problem is, you know, cough of 20 days, but here fever is of 2 days. And that too, Preksha said that is not measured, not documented, that means may not be the significant. Maybe the mild fever may not be, probably parents might have felt. And now the difficulty in breathing, that is also of 2 days. What of the problem now? You know, now put all the symptoms together. Their cough is of 20 days, but mild fever of only 2 days. And even the difficulty in breathing of only 2 days. So what is the likely problem? Chanmejay.
Sir, a viral etiology.
Maybe viral, agreed, but in the viral, usually the fever starts from the beginning. Later on, fever disappears. Cough may remain, but the fever usually subsides. Here on the contrary, fever was not there at the beginning. Fever developed later on. That is also mild of 2 days. But of course, sometimes maybe in viral, any other condition. What I mean to say, you know, on the contrary, fever, cough, breathlessness, if we say, it is a common with the pneumonia. Is it pneumonia, Janmejay? Suppose direct question, if I ask you, in our case, what the Pariksha has given us the information that the cough of 20 days, fever of 2 days, breathlessness of 2 days. Should I consider it is a possibility of pneumonia? Monica, what is your idea? What is your answer? Should I consider this pneumonia? Yes or no? And justification for whatever your answer is there. I think I'm not asking the difficult question. Daily what we are thinking, I want to remind you that this should be your thought process. That's why I'm asking probably the question repeatedly. Yes, anybody? Should I consider pneumonia? Monica? Divya?
Viral infection aggravated by secondary bacterial infection.
No, my question is, should I consider pneumonia, yes or no? Don't mute yourself. At least try to answer. Maybe wrong. Don't bother. You know, meeting is a very good answer that now I don't want to speak. But best ways to speak. I think several times we have discussed how the pneumonia classically develops. That means symptoms, how the story starts, where we think that this is likely pneumonia. Bacterial pneumonia, I'm asking.
Sir, with short duration of fever, cough, and present illness of breathlessness or something like that.
But which symptom comes first? What is second? What is third? Like that. What is the sequence? You know, that is the sequence of the symptoms, and that explains you the pathophysiology. In every case, even suppose viral hepatitis. In viral hepatitis, what is common symptom? There may be mild fever, but significantly reduced appetite, pain in abdomen and vomiting. And then the jaundice appears. And when the jaundice appears, fever disappears. And within few days, even appetite is improving, pain disappears. You know, this is the sequence. From this sequence, we understand that, oh, this is likely viral hepatitis. Like that, I'm asking. Suppose the enteric, what happens? That initially starts with a mild fever and some abdominal GI tract symptoms, pain in abdomen, vomiting, diarrhea, like that. Then the diarrhea and pain in abdomen usually declines, but the fever increases. And there is no any other reason for the fever, obvious reason. Therefore, we say the fever without focus and likely enteric. That's why, you know, what I mean to say, that for every condition, we have some thought process, symptoms. Suppose for pneumonia, what happens? Initially, the bacterial infections of bacteria enters the body, and therefore bacteria may cause the fever. Then it requires some time for the localization. Suppose the bacteria may now localize in the lungs. Then there may be some mild cough. And now suppose there is the exact patch or something has developed. Then what happens? The alveoli are occupied by the exudate, and therefore oxygenation is difficult. Therefore, child becomes breathless. So what is the sequence? Fever, cough, and breathlessness. That is the sequence in a case of pneumonia commonly. Here our sequence is cough of 20 days and mild fever and just breathlessness. So the sequence is different, and therefore probability is not pneumonia. And already we discussed that cough of longer duration, this type of going on, occasionally we can consider that maybe the tuberculosis. Or maybe sometimes the hyperreactive airway disease where cough was there, and now even it has increased the severity, that's for child has become the breathlessness. Or cold and fever together, then probably viral can precipitate it even. It's very common. I think you'll agree with me, am I right, Divya? That on the contrary, hyperreactive airway disease, bronchial asthma, many times it is precipitated by the viral. So this is possible. So actually, what is my idea that In the postgraduate presentation, in the case, please don't go for only mechanical points. Try to understand that in what way I want to explain. What is the likely disease process? And that is more important rather than just to put the symptoms. And that, parents may not be knowing details. So we have to find out exactly that what was the first symptom, what was the second, what was the third. If you ask them, they are able to provide you the information. But that is, I will say, our art, that how we should ask them, right? So that's the point. Anyway, another thing what Preksha has mentioned, increased work of breathing and fast breathing. What do you want to convey? What do you mean? You said that increased work of breathing and fast breathing. What is your idea, Preksha? What do you want to convey? What is your idea?
So fast breathing.
Increased work of breathing is an interpretation. It's not complaint. It is our interpretation. We say it is increased work of breathing.
Yes, sir.
Now, Janmejay, what are the components of increased work of breathing? That means what problem will be there from which you can say that these are the points indicating increased work of breathing.
So, nasal flaring.
Very fast. Always go in a chronology. Don't jump. This is another thing I am always reminding you. Always, body starts with this methodologically. And that will give the idea. Suppose there is some problem, increased work of breathing, then what will be the first symptom? Then the second. And if it is increasing, progressive, then it will increase.
Sir,
I think Hetvi, why are you not speaking? Just put why on the chat box? In the exam, there is no chat box,
So first, tachypnea develops.
Yeah. Very good.
The-
Tachypnea is the first symptom.
Yes, then there is retractions. If upper respiratory tract is involved, then suprasternal muscle
Okay.
retractions, nasal flaring is there, sir.
Anything else now?
If chest parenchyma is involved, then subcostal and intercostal retraction
Okay,
will
so that
seen.
indicates your second point is indrawing.
Yes,
Tachypnea,
sir.
then indrawings at various places. Anything else? Divya.
the grunting.
What do you call it? Absolutely right, Janmejay. What do you call it? Various sounds. Grunting is one of the sounds, but various sounds are there. So please remember, again, I want to remind you, in the past also we
ಕೈ ಕೈಯಲ್ಲಿದೆ ಕೈಯಲ್ಲಿ ಕೈ ಕಣ್ಣು ಕಣ್ಣು ತೋರಿಸು ಕಣ್ಣು ಕಣ್ಣಲ್ಲಿದೆ ಮಗಳೇ ಚಿ
Hello. Preksha, I am audible?
Yes, sir. Audible.
I think there is some issue with my laptop. So I think we'll continue on this mobile. Right? At least I'm able to see. I hope that I am audible to you. Priksha, are you muted?
Yes, sir.
Okay.
Good evening, sir. I am Srinivasan. Sorry for the delayed entry.
Sir, you are late, and my laptop stopped to work due to some reason. Suddenly, I think Zoom issue. What I'm getting the information, but I've joined on my cell phone, so I think we'll be able to continue. Maybe probably it's a little bit difficult.
No, I was preparing for an oration. A few slides I got involved. So I am giving on 23rd an oration on this thing. MC Nair and Dilip Mukherjee oration of this thing.
Right.
Yeah.
Anyway, Priksha, you can continue the rest of the history. Priksha?
Can she quickly go through the slides so that I'll have an idea
Yes,
about
yes.
the age?
Priksha has just gone, I will say 2-3 slides only. Priksha, you can start from the.
Yes. Sir, I'm
Okay,
presenting
fine. Next one.
the cup
Yeah.
since 20 days, a 4.5
Next one. Next slide.
male child with
Yeah,
cough
yeah.
since
I
20
could
days,
see. You
cold
just go
since 3
next
days,
slide.
fever since 2 days, and breathing in difficulty for 2 days.
Yeah.
Sir, initially dry cough, which was dry cough intermittent. Then, sir, it
Okay.
was after
Yeah,
2
got
days.
that. Got it. Next one. Next slide. Yeah.
It developed wet coughing, paroxysmal, more during early morning, not associated with post-acid vomiting and not disturbing sleep. From the last 2 days, cough is associated with breathlessness. Fever is non-documented, low to moderate grade, not associated with chills and rigor, and relieved by medication.
Yeah, next slide. I have gone through it. You go to the next slide.
Increased work of breathing and fast breathing, and negative history, no history of burning micturition or history of contact with animal or allergy.
Anyway, Priksha, what I will suggest, when somebody is speaking, try to listen. Right. Sir also said so many times that there is no need to repeat it. Okay. In the exam also, right? Because
Probably she didn't hear me, sir. So I went through the whole slide very fast. So
anyway,
very clear.
What is the idea of mentioning not history of burning micturition? What was your idea?
Sir, yes, sir. Sir, male childs are more prone in developing UTIs. So, sir, if there is any focus on.
And that child will present the fever, cough, breathlessness. Suppose urinary infection, patient will present to the fever, cough, and breathlessness. So the point is how it is relevant to your. That's why repeatedly I have asked in the past also. I understand you have not just given the thought. Probably maybe this may be from the previous case. May not be because you don't give the thought that whether this I should ask, is it relevant to my case? When the child, 4 years old child, has presented to you with a fever, cough, and breathlessness, how it is, I will say, relevant to ask for this no burning micturition, right? So don't waste the time in the exams also, and don't give the time, I will say, opportunity to the examiner to ask these kind of questions, right? Please take care. In the past also I told. Second thing you have mentioned in the negative, no history of contact with the animal. What was your idea? Animal or allergen?
Sir, allergen.
Allergen or animal or both?
Even we are animals. We belong to animal kingdom only.
Anyway, but you put it. Hello, Priksha.
Yes, sir.
Suppose even here you may be relevant or not relevant, but suppose animal, then that indicates some diseases to the human being from animals. Then that may be the question to you. What are the diseases which you know? And what do you call the type of these diseases?
Zoonotic infections.
No, what is the type of the diseases? What is the title to the diseases of this group? Any idea? I think somebody has put it on the chat box. Yes, zoonosis. Who has put the zoonosis? Please.
Me,
Sorry, may I know, please?
Dr.
Because on the
Deepa
cell phone and the cell phone, I am not able to get the person.
Dr. Deepa Trivedi.
Riksha, madam has put the zoonosis. Dr. Deepa, the problem is that my laptop somehow, due to some reason, Zoom is not working. That was
No
the
issues.
information. It's not working. So on the cell phone, I'm working. So probably maybe some limitations for me.
No issues, sir. No issues.
Now, can you give some examples, Divya? What are some disorders? What we call the zoonosis, as madam said. Give some examples. That means diseases to the human being from the animals.
Sir,
Anybody?
Sir, cat
Brucellosis.
toxoplasmosis.
Very
from
good.
Dog rabies.
Toxoplasmosis. One by one, please. One toxoplasmosis. Priksha. What is another one?
Sir, dogs can at the house for rabies.
So what dog will give the which disorder, which disease?
Rabies, sir.
Rabies, very good, yes. Somebody has put the neurocystic sarcosis. Who put the neurocystic sarcosis? May I know, please? Who has put Priksha? No problem. So that I can take it. My point is I can take it further for the discussion.
Shilpa, sir.
Oh, Shilpa, what was your idea? What is neurocystic sarcosis by which animal?
Pig, any animal meat intake, sir. Even
Yeah.
cow's meat, if it is undercooked.
In parasitology, where it is classified? Any idea?
Nematode.
No.
Nematode. No.
Not trematodes, not nematodes. I will help you.
Tapeworms. Tapeworms.
Oh, yeah, that is cystodes.
Sisters.
That is cystodes, and
Cystodes.
which cystode particularly?
What is the
You know,
dog tapeworm?
I'm sure that
Americanus and Encyclostoma duodenale.
no, which I'm talking of neurocystic sarcosis. Neurocystic sarcosis by cystode. There is Tinea solium. In the cystodes, if I remind you, there is Tinea solium, Tinea saginata, right? Even Echinococcus granulosus, D. latum, D. phylobodrium latum, these are theirs. And this is very rightly you said. So even neurocystic sarcosis is an very important disease, which we may say the zoonosis. Even one more which presents as the fever of unknown origin of long duration. And then we come to know the diagnosis. And not even so uncommon, not very common.
Brucellosis.
Yeah, brucellosis. That is also even with these animal contacts. So what I mean to say, once you speak something, the question is going to be there and you should be prepared. So zoonosis is a very big chapter, I will say. Different diseases. Of course, somebody said very rightly, Ankylostomia duodenale, even Echinococcus granulosus, that is hydrated cyst. All these come under. Priksha, I think you might have not thought of this question, but in exam it happens so. And then I'm not sure in what context you put it over here. No history of contact with the animal or allergen. Anyway, so please keep in mind. Priksha, I think you can go further with your history part. Meanwhile, I hope that my laptop should work. Priksha, are you there?
Yes, sir. Yes, sir. Sir, for this illness, consulted to private hospital before 20 days and symptomatic treatment was given. Sir, past history, sir, the child has been admitted multiple times. First admission was in neonatal period for neonatal hyperbilirubinemia at third day of life, and exchange transfusion was done at that time. Serum bilirubin was 31.1. Sir, second admission at 1.5 years.
Anyway, Priksha, you finish it, then we'll go for this discussion. Okay, one was, as you said, past history, third day of life for hyperbilirubinemia, child was hospitalized, and exchange transfusion was done. Okay, and next second time?
So second admission at 1.5 years of age for cough and cold at private hospital for 3 days and symptomatic treatment was given. And third admission at 2.5 years of age and diagnosed as pneumonia at civil hospital.
Okay. Can we just stop sharing? Okay, yes. I think one more point what you have mentioned. Next slide, take it.
Yes, sir. History of blood transfusion and platelet transfusion during last admission.
During which admission?
Sir, during the when he was admitted for pneumonia. Sir.
For pneumonia, is it?
Yes.
Are you sure?
Yes.
For pneumonia, why the platelets were given? Why the blood was given? I think Hitvi or Mita is there. Mita is there. Who is looking after this patient?
Sir, at that time, there was a reducing of hemoglobin and platelet.
Hitvi, when it was done?
It was done at civil hospital, sir.
At what admission? Among these three admissions, at what admission?
Sir, at last admission, sir.
It was not at last admission.
Sir, at first admission.
Mita, when it was done?
Sir, on first admission, sir.
During the neonatal period.
Yes, sir.
Am I right? Because fortunately or unfortunately, I have seen this patient. Right? So it was during the neonatal period. And among these, now you can just stop sharing. Priksha. Priksha, are you there?
Yes,
Mita?
sir.
Yeah, but how will come to unless you respond? Priksha, you will have to respond that yes, I'm doing or something so that you can just stop sharing. Now the point is, Priksha, what are the bilirubin level at the time of this? You said 31, but what are the direct and indirect fraction? Is it important? You have any idea or you don't know?
No, sir.
I think Mita must be knowing. Mita? Mita, are you there?
Yes, sir.
What was the bilirubin level, direct, indirect fraction? Total 31. These are not the important point to go in the details.
Sir, direct was 1 and indirect was 31.1, sir. Right?
Yeah, direct was only 1, right? So almost 30 was indirect hyperbilirubinemia. Yes. Then what was the cause for this indirect hyperbilirubinemia? What was the cause? Where the baby even required the exchange transfusion immediately. What was the reason for this indirect hyperbilirubinemia during the neonatal period on third day or fourth day of life? Any idea, Priksha? Is it important? I think you can ask Mita, because Mita has seen this. Mita, what was the reason? Mita? Priksha, tell Mita to remain joined. Hetvi, have you seen this patient? Hetvi, whether Hetvi is
Yes.
there?
Yes, sir.
What was your point? What was the indication for accent transfusion, and why this patient was having so much indirect hyperbilirubinemia? What was the etiology? What was the cause for this jaundice?
Sir, indirect bilirubin was raised. It suggests of hemolysis, sir.
But cause, what was the cause? Hemolysis, okay.
So
Okay, come on.
the neonatal period, there is component of sepsis was present.
Was it sepsis? When indirect hyperbilirubinemia, what common things you will check it? For neonatal indirect hyperbilirubinemia, what common conditions you will check?
Neonatal
ABO
cholesterol.
incompatibility.
Yes, Divya?
Sir, ABO incompatibility, RH incompatibility.
Yeah.
Sir, any hereditary hemolytic disorder?
And for that reason, you will have to know the blood group of the baby. So, Priksha, what are the blood group of baby and mother? Any idea? What the Mita is doing? Mita is busy with something?
The baby blood group is B positive and mother blood group was AB positive, sir.
Mita, I think you have to remain present, and Priksha has not taken the history in details, considering that this is something, some problem is there. So, baby was B positive, you said. Mother was AB positive. So it was not RH, it was not ABO. Am I right?
Yes, sir.
Priksha, suppose RH incompatibility is there, what would be the group of the baby and mother?
Mother should be negative and
Priksha?
yes, sir. Hello.
Yes, Priksha.
Yes, sir. Sir, mother for RH incompatibility, sir, mother's blood group should be RH negative and baby should be RH.
Yeah, so blood group of the mother will be RH negative, baby will be positive. So that situation was not there. What is there in the ABO incompatibility?
Sir, mother's blood group should be O positive. And
Yeah,
baby
commonly mother is O and baby is A or B.
yes, sir.
So that situation was also not there, right? So what other the conditions were there? Whether it was investigated? You have not gone into the details of this part of the history, which is very, very important when the patient is facing this problem. Why the baby should develop this? What are the birth weight of a baby? What are the birth weight? You must have taken in the history. You are muted. You are muted.
3.5 kgs.
So birth weight was good, 3.5 kg. Full term baby. No birth asphyxia.
No, sir.
No sepsis.
No, sir.
Then why this patient developed the bilirubin 31, which required even the urgent extent transfusion? Is it not important to know? So I think this is one point which we should know. Okay. And even the baby was given one PCV and one platelets also. Right, Priksha?
Yes, sir.
So why the platelets was given? Did you come to know?
Mm.
Mita, what was the indication for the platelets and the PCV?
Sir, thrombocytopenia since birth, sir.
So that was a thrombocytopenia at the time of even the extent transfusion, it was noted. And for that reason, the platelets was given. For anemia, one PCV was given. Extent transfusion was done. And as you said, there was no RH, no ABO, full-term baby, birth weight 3.5, right? What other investigations they performed for the jaundice? Any idea? Because they must have tried to get the cause, whoever has treated. They must have tried at least.
Won't take, sir.
Sorry? Sorry, I'm not able to reach. Can you repeat it?
I think she said Coombs test.
Coombs test. Okay. Was it done or that is a, may I know, please, because due to this phone, I'm not able to understand that response is from whom.
Deepa.
Deepa Ben is going to respond everything. That's why we have requested for your presence.
Oh, no, she
Anyway.
said Coombs. I think her mic has a problem.
Okay, Mita has said. Mita, not Deepa Ben. Okay, so Coombs test was done. What else was done, Mita?
So DCT was negative and sir, thyroid function test was also normal, sir. And,
Okay. Whether G6PD was done? G6PD deficiency test was done. Glucose 6-phosphate dehydrogenase deficiency test. Was it done? Yes or no? I think again there is some problem of probably net on the side of Mita also. Am I audible, Deepaven?
Yes, sir. You are audible.
Okay,
You
so
are
at least I'm
audible
able.
and the videos was okay. I think for the students having a problem.
Okay.
Hmm.
So in short, if I provide the information, this baby was full-term, birth weight was 3.5. There was no RH problem, not ABO, not infection, not even the hypothyroidism what they got it. Coombs test was negative. Probably G6PD deficiency test was also normal. That means there was no deficiency. They tried their best, but they could not decide the cause, but treated, and with the exchange, baby was improving along with that phototherapy, and it was discharged. But their problem that even the platelets were noted from the beginning thrombocytopenia, and that also they didn't get the cause. And that's why probably that was the reason for the platelets transfusion. But again, with this not much improvement, baby was discharged. This was the information.
The only important thing that rest students should remember is that when you have acute hemolysis, you must not do the G6PD test.
Yeah.
It will give false negative because young reticulocytes have G6PD enzyme. So it's always better not to do the G6PD enzyme level on the day or the next day of hemolysis. Wait for some retic count to stabilize. How will you know that the hemolysis stopped? You have to do a serial retic count. If the retic is normalized, then you should check for G6PD. And or remember, once you have done an exchange, you have given blood from outside. Again, it will be false because the blood you use for exchange is an adult who is not G6PD deficient. So we still don't know whether the patient has G6PD deficiency or not.
Yeah. I think a very important message, which I'm sure that I discussed during the round also, as Madam said, and please remember, this is very common mistake in the practice also, that once you collect the blood at the time of presentation with a severe hemolysis, and if you go for the G6PD deficiency test, in spite of the deficiency, you are not going to get it. The reason is, you know, that already deficient cells have been lysed and new cells are not available. So let the cells with the deficiency come in the circulation, and that requires some time. And suppose here's the situation like exchange, suppose if you are done, then probably the taste of that blood you are doing donor's blood. So again, probably that's not the right time to do this, even the test. And suppose if you are having the strong reason for this, even the G6PD deficiency, at appropriate time, we should do it so that you can decide whether the child is having really deficiency or not. So this is very important and I think very common mistake in the practice. But Madam, for your information, later on, it was after few years it was done again by somebody else, and that G6PD deficiency was not detected.
Okay.
That means it was normal. So that I think later on I went to the. Fortunately, I have taken the round of this child, so some of the information that the students may not be knowing, but I know that even 2 times probably somebody else did it even, and every time it was found that there is no G6PD deficiency. This was the information regarding neonatal. Then let us go further development. I think gradually you have the clear picture and we will be back to you for your opinion. So Preksha, now can you take the history further? Preksha, are you there?
Yes, sir.
So you should respond so that I come to know that you are there, right?
Sir, sorry, sir.
Sometimes the same thing happens in the exam. Be quick, prompt, and very, I will say, dynamic.
Yes, sir.
Yes, go on, please.
Sir, family history. Sir, history of TB in grandfather before 1.5 years of age and treatment taken for 6 months, and no history of asthma or allergic disorder in family. No history of blood transfusion in family. Sir, birth history. Antenatal was uneventful. Natal full-term normal vaginal delivery. Cried immediately after birth and 3.5 kgs of birth weight. Postnatal history. History of NICU admission for neonatal hyperbilirubinemia. Exchange transfusion was done. Sir, immunization history. Immunized till 1.5 years of age as per national immunization schedule, and Vicimap was present on left upper arm. Sir, dietary history. There is 1.3% deficit in energy requirement and 20% deficit in protein requirement, sir. Sir, general examination.
Okay, can you just stop sharing again?
Yes, sir.
I hope that other students are there on the screen. I'm not able to see them, but I'm sure that from the response I will be able to make out. Preksha has mentioned the family history. When this background is there, that the baby required the extended transfusion due to the indirect hyperbilirubinemia, and there may be some condition with the hemolysis. Suppose if you suspect it, what very specific points you will ask in the family history? Divya?
Sir, history of blood transfusion, history
Okay,
of consanguinity.
Okay, in consanguinity, even give the some idea that what is your idea? Suppose consanguinity, what is your idea?
Sir, when if mother or father is sickle cell trait or beta cell trait,
No, my question is, what is the importance of consanguinity? Suppose consanguinity is there, what does it indicate? What does it favor?
sir, chances of
point
hereditary
is,
disorder,
point is, genetic. Yeah, somebody has put it very rightly. I'm not able to
autosomal
make out the
recessive.
person. Autosomal recessive disorders are common with the consanguinity. So that should be the answer. And then you can think that which are the autosomal recessive disorders in the various fields. Suppose it's hemolytic anemia, then you can find out that which are the disorders where autosomal recessive disorders can be there. And suppose the consanguinity is there, then probably more chances that this disorder may be there. I think that's the idea that why we go for all these points, right? Okay, what was the second point? History of transfusion. What is your idea of the transfusion? Suppose family history of blood transfusion is there. How it favors you, how it helps you. Divya.
Sir, low hemoglobin or any thalassemia-like disorder may have
Okay.
repeated transfusion
So
history.
what do you call it? Actually, always I'm giving the idea that talk in the language of the science. Suppose in the one sentence, if you want to answer, the answer should be transfusion dependent disorder.
Okay.
Right? That may be the transfusion dependent hemolytic disorders. That is one answer. Then what are the disorders? Okay, that can be the anything. Most common thalassemia, yes. So the point is, your answer should be in a language of science. That suppose the history of blood transfusion in the family, that indicates the possibility of transfusion-dependent hemolytic anemia is there, right? Okay, I understand. But the point is, once you conceive the idea, express in a proper methodology so that it becomes impressive and even the clear also. Very good. What other history you will ask, Divya? One is the transfusion,
Sir,
continuity. Very good.
Sir, features of hemolysis in family, like history of splenomegaly or
Okay, anything else? Suppose some splenomegaly was there, and which was a reason for this? Yes, somebody has mentioned history of any surgery. Which surgery? Not any surgery, very specific surgery. History of splenectomy in the family. Right? History of splenectomy is in the family. Then which disorders are there with the splenectomy? Suppose in the family splenectomy was done to some other sibling or some even the relative. Then likely which? Yes, hereditary spherocytosis. I'm not able to make out. I think just doctor is there. Can you rename so that I understand that from where I'm getting the response? Yes, hereditary spherocytosis. Sometimes later on it is done, even maybe in a case of thalassemia. So history of any other thing, any history, still. Surgery one is splenectomy. What can be the other surgery one? Divya, any idea?
no, sir.
What happens in a case of hemolysis? Any hemolytic condition is chronic.
Gallstone, sir.
Yeah, gallstone. And therefore, the history of gallstone, or due to the gallstone, even there may be the cholecystitis. And somebody even might have required the cholecystectomy. Therefore, the history of cholecystectomy, history of splenectomy, history of blood transfusion, history of consanguinity, all these points are very, very important. I think before we go further, Dr. Deepaben is there. Madam, are you there?
Yes, I'm here.
So I think the family history, can you just highlight? Because, these are the very common conditions for the students also, and otherwise I think in the practice also. So what family history is important with the reference to these conditions?
Yeah, as the students had said, it is very important to ask whether there are anybody in the family who had splenectomy, gallstones, cholecystectomy, somebody who needed emergency blood transfusion, like normal was there, like a auntie or somebody who was normal but only needed blood transfusion suddenly because of a sudden hemolytic crisis. So blood transfusions, cholecystectomy, splenectomy, and you can draw the tree, I mean, depending on whether it's autosomal dominant or autosomal recessive, whether they
Right.
were it missed a generation or not. So you have to draw the family tree then.
Yeah, so what madam said, we should go for proper pedigree preparation. That pedigree will give the idea. Suppose by chance the disorder is there, that will give the idea whether it is some autosomal recessive, autosomal dominant, and that will give the even idea that which condition is likely. Suppose autosomal recessive may be the thalassemia-like, autosomal dominant probably maybe the hereditary spherocytosis, or even probably sometimes even hereditary spherocytosis can be both even types of the transmission. But the point is, at least we can have some idea. We can think something. So pedigree is very important. So all these points, Priksha, I think in the history we should take it. Now you can go for the examination. But I think Madam has noted the gradual points that what are the issues with this child.
Yes, sir.
Yes, Priksha, go further on the examination.
Sir, general examination. Sir, child appears well nourished and he was conscious and alert. Sir, Vital's temperature is 98 degrees, measured by digital thermometer in right axilla. Pulse rate was 144 in right radial artery, with good pulse volume and normal rhythm. Respiratory was 50, with regular thoraco-abdominal type of respiration, and oxygen saturation was 99% on oxygen support. Sir, head-to-toe examination was normal, sir. Sir, anthropometry. Yes, sir.
Okay, go ahead.
Sir, anthropometry, sir, weight was between 0 to +2 SD and height was at 0 SD. But, sir, no under the sir, systemic examination,
So
sir.
hold on. How can his weight expected be 30 and he's 18.5 with a 20% protein malnutrition that he's taking? He's overweight, right?
Yes.
Is it, Priksha, was it overweight?
Uh, Between 0 to +2. Yes,
Like,
sir.
expected is 13 and you have put his weight as 18.5.
Even
Yes.
Priksha, can you make it full screen, your presentation? Is it possible? And have you growth chart? I think growth chart will make this point clear.
So,
You have the growth chart after this anthropometry.
yes, sir.
You can check on the growth chart that what does it show.
Sir, it was 18 and expected is, sir.
No,
around-
you are not prepared the slide, growth chart. You don't have the slide. Riksha, yes or no?
Yes, sir.
Then show the growth chart. And if it is possible, can you make it full screen so that I think it becomes easy for us to see? Okay, I think you are also finding difficulty in managing.
I do.
Okay, what does it show, the growth chart? Does it show the overweight?
Yes, sir. The weight is between 0 to +2 SD.
Okay. Sorry, can you show the where is the?
I can't see any mark.
Sir, expected is I think 18 kg.
Is it plotted? Because I have not, something is.
Am I audible now?
Yes, sir.
Yes, sir.
Audible.
Okay. Fortunately, now I am on the laptop, so I'll be able to understand properly. Okay, so Preksha, I think what Madam pointed out that you are reading on the group chart and they are not telling, so we'll have to keep in mind. Anyway, you can go further.
Yeah, let's go ahead.
Let's go ahead. It happens so in the exam also, so don't worry. These problems are going to be there. Madam is just pointing out. Even you have taken the chest circumference. What was your idea of chest circumference?
Chest circumference should be
What was your idea to take the chest circumference? Now, 4.5 years old child, when you are going to take it? Anyway, let us go further.
yes, sir.
Can you make it full screen? You know how to make it?
Go to slideshow and click and then start
Yeah.
with current. Go up there. There's
I think-
something called a slideshow
I think somebody
next
is
to
there
animation.
Yeah. If it is not possible, go ahead. Don't worry. Riksha, suppose if it is not manageable, don't worry. Go ahead.
Also, respiratory system on examination of upper respiratory tract, nose and pharynx are normal. Nasal pharynx is present.
Riksha, your slide is seen after that. So can you go to that particular slide? Yeah, now it has come. Okay, but it disappeared.
Yes, sir. I'll share it again.
No problem. No problem. Don't become the nervous. These problems are going to be there. I think one thing I would like to convey to all the students, any these of the disturbances happens, even in the exam, you should not get nervous. Because examiner is able to understand that the problems can occur. It is not under our control. Sometimes child may cry, may not allow you to examine, or even sometimes relative may be anxious. And therefore, I think we have to take with very patience and calmness. So don't worry. These are also, I will say, parts of training. You can take your own time.
Yes, sir.
Will not become the impatient. So don't worry. Right.
Yes, sir. Actually, sir, it's showing in the PC that the slideshow is going on, sir. But
No problem. No problem. But your voice should not go down. Right.
Yes.
Keep the same voice.
Yes, sir.
Okay, go ahead, please.
So, respiratory system examination. On examination of upper respiratory tract, nose and pharynx.
Slowly.
Yes, sir. Nose and pharynx are normal. Nasal pharynx is present. Examination of lower respiratory tract on inspection, trachea is centrally placed. Suprasternal and subcostal retractions are present. Bilateral chest expansion is present, and bilateral symmetrical chest movements present. Apical impulse present in fourth intercostal space. Sir, on palpation, trachea was centrally placed. Bilateral chest expansion was symmetrical.
Again, your slide is not changed. Can you go to the next slide, which you are addressing?
Yes, sir.
One by one. Yes, now the slide has come.
Sir, on palpation, trachea was centrally placed. Bilateral chest expansion was symmetrical. Apical impulse was felt in fourth intercostal space on mid-clavicular line. Vocal and tactile parameters are absent over the right side. On percussion, dullness present from right fourth intercostal space, and on auscultation, bilateral V's with coarse capitations present. Bilateral air entry is present.
Okay, Riksha, what this indicates, Can you go to the respiratory system?
Yes, sir.
Yeah, I think here you have mentioned the upper respiratory normal, but nasal flaring present.
Yes, sir.
Right. Let us go one by one. Which are the points you have noted? To save the time, I'm coming to the specific areas. Second, you have noted in the lower respiratory, suprasternal and subcostal retractions. So flaring is there, indrawings are there, and bilateral chest expansion, you said present. What do you mean by that? Vishal? Vishal,
Yes, sir.
Vishal, would you like to change, or is it appropriate what she has considered? Priksha, anyway, no problem. Now I think you can go to share later on. Let us first define the respiratory system.
Yes, sir.
She has mentioned this chest expansion present. Is it right, I will say, statement, or would you like to change it, put in some other way? Or what you want to convey? Suppose chest expansion present. What does it indicate?
Sir, maybe fluid collection, or maybe emphysema, or
But in this condition, there will not be the chest expansion at all. So again, if I remind you, whenever you are putting, please read it twice. That what actually your statement and what does the statement convey? If you put chest expansion is going to be present. Here you want, suppose it is diminished on either side, whether it is symmetrical, whether it is asymmetrical, and suppose asymmetrical, on which side it is diminished. So the statement should be the meaningful. Just expansion is going to be there, maybe diminished, right? So now if you see over here, I think what was the respiration rate you mentioned? Priksha? What was the respiratory rate? Sorry?
Sir, 50, sir.
Somehow your voice is not reaching clearly.
Sir, 50.
Okay, respiration rate 50 for this 4.5 years old child. So it is tachypnea. So tachypnea is there. Subcostal and suprasternal indrawing is there. Nasal flaring is present. Just expansion at this, okay, she had mentioned normally. You can go further. Riksha, go to the next. Go to the next slide.
Yes, sir. Sir, sir, abdominal system, fever was 3 centimeter palpable below right coastal margin and mid-clavicular line. Fever span was around 7 centimeter. Sir, consistency of fever was firm and smooth, and the spleen was palpable 4 centimeter below the left coastal margin towards the iliac fossa. Percussion. On percussion, dull note is noted from right fourth intercostal space 4 centimeter below right subcostal margin at mid-clavicular line, and auscultation, vowel sounds were normal.
Go next. Go ahead.
Sir, abdominal, the cardiovascular system and CNS examinations were normal. Sir, investigations.
Okay, I think just stop sharing for a while.
Yes, sir.
I think I understand the Priksha is a junior resident, so no problem. But particularly this is for the senior residents and exam going. That during presentation, examination findings should be very appropriate. First, go methodologically. I will say mention in the standard clinical examination books. And that is inspection, palpation, percussion, auscultation. That should also come in a very specific order. And before you make the statement, ask yourself that what does this statement convey? What is its meaning? And whether are you able to explain on your possibility or diagnosis. If the finding is obvious, you will have to, you cannot manipulate, but try to find out the probable explanation. So otherwise, from the beginning, from the primary discussion, it goes against your favor. And then it invites a trouble. So I think during this time, at least your presentation should be very clear. So in this patient, suppose if you have put it that there is an increased work of breathing, because tachypnea is there, indrawing is there, and some sounds. I'm not sure within the auscultation, did you get any sound? So put it properly. That will give you the idea. Later on, try to find out that where is the anatomy. Is it the airway disorder? It's a lung parenchymal problem, it's a pleural problem, or it's an interstitial problem. And then probable your diagnosis. And then you can go for the differential diagnosis and discussion. So I will say during presentation, come with all the ideas or thoughts. That is very important in the exam also. Here you are getting more time. In the exam, you are not going to get the more time. So I think your mind should be properly trained, and I will say very activated, that how you are going to put it with each system. This is just, we are taking the respiratory system. I think here in this patient, there was another big problem, which probably we are going to discuss. From the history, we came to know that respiratory problem was probably from the episodic, and that is following the viral. So maybe the episodic viral visa or something, what we say in this patient, which probably worked with this treatment part. But the important aspect, what we got in the neonatal period, hyperbilirubinemia, which required the external transfusion up to the level of 30, for which probably they didn't get the exact cause. And even the thrombocytopenia was noted from the birth. Now, I would say to focus this problem, let us go for the investigation so that we can utilize our 30 minutes and we can take the best, I would say, opinion from Dr. Deepa. So now you can go. Respiratory system, I don't go into the details at present. It requires more detailed discussion, but at some other time, I'll say we'll take the opportunity. Priksha, now we can focus for the investigations. Priksha, you are muted. Unmute yourself.
Yes, sir. Sir, these are serial investigations.
And go slowly, because people have to understand you, to follow you, not just to read out. Right? I understand during the anxiety, during this time, even in the exam, the same thing happens. But again, I want to train you that we have to follow properly so that person can understand and they can follow us, right? So take with that speed, not even so slow also. Both the things we'll have to keep in mind. Okay, go ahead.
Sir, HB serially done in 2019, suggestive of decreasing trend.
I think Priksha, that's why I'm telling you. 2019, probably people may not be knowing. You can say that this is at the time of birth.
Yes, sir.
Right? So that person can understand, follow you.
Yes, sir.
That the 25th February probably may be the first day of admission, probably on 3rd or 4th day. Am I right? Yes. So these were the investigations on very first day, so that person can follow and they can think even. Yes, okay, sir. Go ahead.
Sir, there is an increasing or a decreasing trend in hemoglobin levels, sir, and increasing total counts. And sir, the platelets, I think, sir, when they were...
Priksha, let me take the liberty over here so that even others can follow us. And Mita, suppose if I don't know the details, you can correct me. I think this 25th February 2019 was the day of admission. Probably that was third or fourth day. During that time, we can say that hemoglobin was 18.6, which is normal for the newborn. Count was normal, but the platelets were low from the very first reading. Hematocrit, we can see that 51.5 may be normal for this newborn. MCV was little bit raised. MCSC 35.9 normal. MCSC okay, and I think Dr. Deepaben is there to interpret us. If it is something, suppose her interpretation different, she will correct. Later on, probably this was 26 was before exchange or after exchange. I'm not sure. Ita? Probably must be because exchange probably they did on the very first day. So 15.7 hemoglobin count, okay, but you can see the platelets again low, 12,000. And again, indices not much change. Later on, we can see that neonatal period, almost hemoglobin was okay, but the constantly platelets were low. I think this 28th February platelets little bit were corrected, maybe after the platelets transfusion or the PCV. Both the things were given. And again, 23rd March 2023, that means just 6 months back, again the hemoglobin was 14. If it is 14, I think it's a good, because this must be the age of around 3.5 years or so, or almost 4 years. Count was okay. Platelets somehow, I think that was only reading which was more than 2 lakhs. All other readings were low. Can you go to the next? Yes. Next slide is probably she has put here with the bilirubin levels. On pre-exchange, it was 31.1. Almost everything was indirect component. This must be the after, I will say, post-exchange. Later on, probably following the phototherapy. And within the few days, in a week time, at almost it was around 8. So I think responded well to the exchange transfusion and phototherapy. Next. Again, these are the investigations recently from 8 September to 16 September, that means few days back only, during this last admission in short. And hemoglobin is fairly good, count almost normal, but we can see the platelets constantly every time low and significantly low. Hematocrit we can see lower side, MCV almost borderline, MCSC almost normal, RDW, if you can see, it is raised. And these are the values which had been given. I think, Deepaben, you can take over here. This is very important role, that how you interpret and how we should take all these readings. Dr. Deepaben?
Yes, yes, sir.
Yeah.
You can
I
hear
think
me?
if you wish, she can go to the previous slide also, if you want.
No, it's fine. As you have
Okay.
interpreted it,
Yeah.
basically, I think that 18 was at birth, probably. And then after the hemolysis, it went down to 12 or 13.
Right.
And then PCV was given, which is, but it is very strange to have thrombocytopenia at birth like this. It's a very googly question that why did the child have thrombocytopenia early, especially because you would think, if you think of torch or something, you think of low birth weight and kids having some complications other than not having pneumonia or anything else at birth. There is a gap of 4 years where we don't know the platelet or the CBC counts or the kid had any problems, but maybe it was normal. But as far as we can see, yes, the
No,
MCV
no, madam,
is
it was not normal. Every time thrombocytopenia have been noted from birth.
from birth. Okay,
Yeah,
so 2021.
Yet anytime it was not normal.
Okay, so there's been persistent thrombocytopenia since birth.
Yeah.
Okay, so with that we have to investigate what is the cause.
Yeah.
Hemoglobin is on the lowish side, but again 10 to 11 is okay. MCV is 70 to 80 something, so it might be a mixed deficiency of iron deficiency and macrocytosis. RDW is wide, that shows that there is different sizes of red blood cells, and sometimes there is production, sometimes there is maybe hemolysis or breakdown. But otherwise, the white count is also decent. There's not much we can say about
Yeah.
it.
Yes. You have the other slides, Riksha? You can go to the next presentation. Okay, I think this G6PD was recently done. And was it normal, reported as?
Yes, sir.
Okay. Madam, you can take it further, LDH and ferritin. I think
Yes.
you are the
So
right person.
G6PD is normal as per the range probably. LDH is very high. Now, a high LDH is a marker of cell breakdown or cell turnover. So whenever you have severe hemolysis, your LDH can be high, like in autoimmune hemolytic anemia. LDH can be high in malignancies like Burkitt's lymphoma, leukemia. LDH can be high when you have even B12 deficiency, severe B12 folate deficiency. Again, same thing. The cells are breaking down because they're not properly formed. So LDH being high is a marker that there is some cell breakdown and turnover. If you look at the ferritin is normal, iron and TIBC is within normal limits as such. So at least this is not a regular iron deficiency anemia. I think Coombs had been done previously also and now also. So Coombs is negative. The retic count obviously is high. It's 7.1%, but the corrected is about 4.8, which is still okay. It shows there is some hemolysis, but not terribly high. This we have discussed the mother's blood group and the baby's blood group. So we still don't have a cause. Anything
Riksha,
else we have?
Riksha, yes, whatever you have, you can go.
Next slide.
Peripheral smear RBC series shows reduced RBC mass, normocytic and normochromic, anisocytosis, poikilocytosis, schistocytosis, and microcytosis polychromasia seen. Platelets are mildly reduced with few large and occasional giant platelets. No malarial parasites are seen.
So basically, whenever you have platelet destruction or what we call it as immune mediated destruction, you get a bone marrow response. And the bone marrow response is usually you produce giant platelets or large platelets, or you have some disorder where you produce giant platelets, like Bernard-Sorier, Glanzmann's thromboasthenia or something like that. So we need to kind of think about it. The RBC series, again, same thing. There is some cellular stress. So we are having cells. What is anisopoikilocytosis? Is cells of different shapes and sizes with different amount of hemoglobin in them. Of course, schizocytes, it's very important that when somebody sees schizocytes, we need to know whether it is 3 per high power field, 5 per high power field, and it has to be in an oil immersion. So it's very important because schizocytes, again, is a sign of hemolysis and presence of hemolysis. So again, whenever you see somebody reports a schizocyte, your pathology should be able to tell you it's significant or not. You can have a few schizocytes, they might not be significant. So very important to see if you see schizocytes, how many are there per high power field.
No, just madam, if I inform you,
Sure.
Dr. Sneha, she's really very good, I would say, pathologist. She talked personally to our Dr. Pratna, who is looking after this patient, that this picture is highly suggesting some hemolytic process from the peripheral smear, she said. That and that what you talk, the same that this particularly the schistocytes, she said that very important cells which I am getting in this peripheral sphere. So I remember that even she conveyed to me, Dr. Pratna, that this is the impression of Dr. Sneha. And that was her, with these ideas, even she examined the smear in the details.
Okay.
And therefore, she made the comment for the platelets also, that definitely platelets are also not normal, count low, but at the same time, morphologically also, they are larger in size.
Okay.
Yeah. Further, Riksha, then I think together we'll try to decide
Find out
from,
what's wrong.
yeah.
So USG abdomen.
I think only mention the positive points. Here, probably liver, okay, it was enlarged, but the gallbladder were distended and that they got the gallstones. That is important. Even some changes of cystitis. Spleen is also enlarged. Lymph nodes were not important.
Okay.
And this was the interpretation. That means liver is enlarged, spleen is enlarged, gallstone is there, cholecystitis. These were the points on USG abdomen. Anything else now, Preksha, you have? Okay, now I think you can stop sharing.
This is really interesting case.
Yeah, Madam, just because this was discussed to me, I think for just our recollection, you know that here 4.5 years old child is brought to us, brought for some respiratory problem acute, that was a different issue. But in details, we noted that there was a neonatal jaundice on third or fourth day without any obvious reason. RHABO, nothing was there. G6PD, later on also it was confirmed. Coombs was negative. Exchange was done. But from very first day, they noted the thrombocytopenia, which is persistent even today also, multiple times. One transfusion and PRP was given, that was there. No RH incompatibility, no ABO incompatibility. G6PD deficiency is not there. Thyroid function tests were normal. Child has the hepatosplenomegaly, no lymphadenopathy. Smear shows these changes of the hemolysis with a raised reticulocyte count. I think iron ferritin, ferritin little bit raised rather than normal. And gallstones are there, cholecystitis changes are there, and hepatosplenomegaly and constant thrombocytopenia. Now, having this picture, we want your opinion that what is the likely problem and how we should proceed further.
So basically, see, whenever we see there is anemia, there is thrombocytopenia. So there's two lines which have a problem. WBC is normal. All the MCVs are almost 100, 90 to 100. So there is macrocytosis more predominant. And whenever we think about this, what we need to know is we have to remember basic biology. You have a red cell wall, red cell structure, and there is something inside the red cell that is the hemoglobin and other enzymes. So if you look at the wall, right, you think about hereditary spherocytosis, hereditary elliptocytosis. Now that has not been picked up in any peripheral smear. Small round cells have never been reported. So I think we can kind of rule out elliptocytosis, spherocytosis because you are not seeing it in the smear. Now, if you think about hemoglobinopathy, right? If you think about hemoglobinopathy, yes, there is hepatosplenomegaly, there is some kind of anemia, but it's not very severe. To think about thalassemia intermedia, you might have a hemoglobin 7, 8 usually by this time, by the age of 4 if you have not transfused except in the neonatal period. And if there is such severe hypersplenism, is that the cause of secondary thrombocytopenia? No, because the child is having thrombocytopenia from the beginning. So this cannot be attributed to the hypersplenism per se. So kind of hemoglobinopathy, we'll just put it on the side. So then what we think about is some enzyme like G6PD, glucose 6 phosphorase, pyruvate kinase. Maybe there is some other enzymopathy which is causing the red cell to be unstable and that is getting hemolyzed. Because these are all Coombs negative. Because there are structural problem in the red cell which is causing the red cell to break down. So I think, unfortunately, in this case, if we do a bone marrow, again, microcytic, we could think about sideroblastic or congenital dyserythropoietic anemia. Macrocytic, again, kind of goes against it. There are rare disorders like thiamine responsive anemias, which are again genetic disorders where you can have anemia and thrombocytopenia. So even if we do, obviously we will do a bone marrow for the sake of workup. You might see erythroid hyperplasia, adequate megas. That kind of shows that your bone marrow is functioning okay. But ultimately, you might need a next-gen sequencing or a genetic test in this child if you want to kind of diagnose the cause. I don't know. This is really difficult, even for me. Sir gave me a really difficult case today.
No, actually, we had this discussion with all these points, but we wanted further from you. Now, certain questions. Is it possible with these spirocytes, even if not seen the circulation, or probably somebody might have missed or something like that? Or another thing, just I want your attention or focus that which condition will be present in the neonatal period which requires the XN transfusion. Commonly, let us think the clinically. Then we'll go for confirmation.
G6PD hereditary
G6PD is
spherocytosis.
known.
And there are a group of disorders called congenital non-spherocytic hemolytic anemia.
Right.
That is CNHSA. Those can present also in the neonatal period with hemolysis. for whatever reason.
Because I think what was my idea that we can focus what we have and we can try to get these conditions related to that presentation. And I think neonatal period with severe hemolysis presenting and require the extent transfusion in more than 3.5 kg weight, that very clearly indicates that some very specific condition is there, significant responsible for the hemolysis. From this point of view, if you focus, as you said, spirocyte is common, and with the spleen, with the gallstone, with the cholecystitis, probably it favors. Of course, the family history is not there, which may not be every time.
Yes, it's possible that spirocyte may not have been seen.
Yeah.
So,
and suppose for that, if you want to go, can you suggest any specific test besides
yes,
osmotic fragility?
there is something called the eosin malide test,
Right.
which is a flow cytometry to
Flow
see the
cytometry.
structure.
Yeah.
So eosin malide test, EOM5 test or something, it's called. That
I
can
think,
be done.
Mita, I think you can write down and we can go for further work. Fortunately, parents are also good and they want the answer from us. And therefore, we thought that let us try to at least to look at something, if at all, if you get it.
Yes.
So that is one point. I'm sure that suppose G6PD, then the spleen is not expected. And then it will go muscle acute, but I think once the patient recovers, then should not go for this.
Should not go.
So I think, and even 2-3 times normal, so we may not keep the doubt for that.
Yes.
So anything else beyond that now?
All others are rare disorders which
Yeah.
are genetic in nature. We might have to go for a genetic test to find out.
I think in genetic, what we can say, just genetic for the hemolytic anemia.
Yes, you can get a genetic test for hemolytic panel.
Panel.
There is a set of diseases which are covered.
Any idea of the cost you must be knowing?
It's not very expensive, sir. It's about 15,000-16,000 rupees, I think.
Okay, so
sometimes even in some labs can do it for a discount even for 12,000-13,000 rupees.
Right. So I think
so it's not
because now we'll have to explore the various possible investigations for confirmation. Probably clinically we have the limitations now.
Yes. Is the child able to hear properly?
Yes.
No
Yes.
hearing.
We have not done the specific test,
but the parents don't
apparently
complain.
yes, parents and even apparently because child was there in the ward for I think a week or so, and when we were interacting, I also interacted absolutely fine.
Because I've seen 2 cases where we have like this anemia, thrombocytopenia, thiamine responsive.
Thiamine responsive.
Anemia. Anemias, and they have congenital, they can have deafness and also develop diabetes mellitus later.
Okay. I think deafness we can verify one.
But if he's hearing, family says he's okay, then less likely.
Because as you said, and thiamine can present with this thrombocytopenia.
It can present, yes.
Because this is another thing which we'll have to link up with the hemolysis, thrombocytopenia, which is since what?
Correct.
So again, we'll have to think the condition which can present with the hemolysis and even the thrombocytopenia.
Yes.
Yeah. So I think this...
Does he have any mass in the liver or anything? But again, WBC will be less also.
No,
like something like a hemangioma, which is where all the cells get collected. Nothing like that,
no,
right?
Madam, nothing like that. Nothing like that.
Yeah.
And that you said that somehow it came to my mind and I talked to them that whether there is the possibility of consumption.
Yes.
But they check it. And they said that sonographically, when I requested the radiologist, they said that simply enlarged organs, but not any specific. Yeah. Okay. And apparently, even no any other place also any evidence of hemangioma.
Hemangioma.
Externally also. So I think we can go for one is the for spirocytes of by chance if we get it, or another is the genetic test, as Madam said, which may help us. And for suppose thiamine, is there any specific test for thiamine deficiency?
That is also a genetic test. It is again, it will come in the hemolytic panel.
It will come in there.
It's called thiamine responsive anemia.
Okay.
So there is a specific gene mutation.
Yeah.
For that also.
Anyway, I think these are the points which we can keep in mind.
Let me know, sir, once you have the answer.
Yes, sir.
I will also be interested to find out.
Certainly. Fortunately, or I will say fortunately for us to learn, but unfortunately for the patients, we had some 4 or 5 this type of the issues with the different patients. And the very unusual conditions where we got it, we could help the patient. But certainly, and as you said, I'm insisting, our main idea of the discussion, at least students can have the idea that methodological working is very, very important.
Correct.
I think neonatal jaundice, one should go at the depth that what was the, fortunately parents were knowing many things even when the records were also not available, but they had the lots many informations. Anyway, I think as Madam said, we'll have to end over here with this homework, what she suggested. We'll do it, and I'm sure that the patient is ready. We'll be able to manage with some help even from others. And let us know, suppose by chance if we get the diagnosis. But thank you very much. Your presence made the difference in our thought process. And I'm
Thank
sure,
you, sir.
and I'm sure more so, particularly for the students, they also know that even in spite of these many years working in the field of pediatrics or hematology, even teachers don't have the answer.
Answers, correct.
Right. So I think students should not be afraid of it. Always speak whatever we know, but at least continue to speak, continue to participate, continue to think. Then and then we can learn the medicine. Yes. Otherwise, sir, Srinivasan sir, we are waiting a word from you.
It's a very puzzling case. Of course, we know it is hemolytic anemia, but to pinpoint what it is, what enzyme or what this thing variate is very difficult to say. Yeah. I hope we will get an answer soon.
Yeah, we will try to work up as Madam suggested.
Yeah, gene study is very important to find out what it is.
Thank you very much, sir. And thank you very much, Dr. Deepaben.
Thank you.
Even last moment, sometimes we catch you and you are available.
Yeah.
That shows your, I will say, interest in the teaching and learning, even both. Then
Sure,
and then person will get the time. Otherwise, most of the time people are busy. But
No,
those
sir,
who are
anytime.
but those who are ready to learn and teach, they are always getting the time. And Deepaben is one of them. And thank you very
sir.
much.
Thank you,
very
sir.
much.
Good night.
Good night, all of you.
As we see
Good
that
night.
in September, we'll complete the 3 years of the PG Clinic.
Wow, congratulations, sir. Very nice, very nice.
And Srinivasan sir is constantly present, I will say, for all the 3 years.
I am a learner, sir.
At the age of more than 75, sir is
Wow.
really
78.
Thank you, sir.
78 years. Yeah.
Wow.
So by mentioning Priksha and with all the students that at the age of 78 years, he has not missed even the PG Clinic. Right. And we have to, I will say, how our journey is, we have to learn. So I think that's very important. We'll have to take the inspiration from such teachers. And
Yes.
that's why probably
I go daily to Jipper also, sir. Meet your daughter. She must be telling you.
Deepaben, I'm fortunate that Alapi, my younger daughter, is doing this fellowship in the JIPMER and sir is there. So
very nice, very nice.
Even she is getting, and we can learn from the institution. She's enjoying
Is she attending that development workshop, sir, in 2 days conference?
Yes.
In SRMC, Chennai? Is she coming?
Sir, I'm not sure because I have not taught.
Because I am giving an oration there. Dilip Mukherjee and Nair oration.
Congratulations, sir.
Thank you, madam.
है ना हमारे
Priksha, I'm audible.
Yes, sir.
Yes, sir.
Diksha, are you there?
Yes, sir.
Yeah. We have to remain both of us because
Yes,
we
sir.
are the last people to leave.
Yes,
Again,
sir.
there was some problem of the, I think, net on my part. Anyway, but now we have completed. Your, I will say, case was definitely good. I understand for the any junior person, still your preparation were good. Still, we are going to be the better in the future also. And all other students also participated very well.
Yes, sir.
I think as per the planning, we'll go for the workup and let us try to know that we should get the final diagnosis. I should thank even all other students also on the attendees link. And next time, next Tuesday at 6 o'clock, we'll meet. Meanwhile, I should appreciate even the DIP person, Shweta, our President, Dr. Upendra, and Secretary, Dr. Vineet Saxena, for providing this platform. Thank you very much. Good night. And we'll be there on the next Tuesday at 6 o'clock. Good night.
Thank you, sir. Good night, sir.